So let's take a look at case 1 as we are extracting teeth today and how we are looking at the potential treatment for these patients. Yes, I know there are a lot of wonderful devices out there in order for you to extract teeth, but also your elevator and forceps still can do the job as long as you are doing atraumatically. And of course, as I mentioned earlier, the first thing is you determine where the mid-buccal bone is. You are placing your implant, and as you can see, that entire buccal complex is not touched. Is not touched during your site preparation, and is not touched during your implant insertion. And that is very, very critical. And of course, not to mention that the site has to be clean and debrided if you suspect that there are some soft tissue somewhere at the apex following endodontic treatment or scar tissues. But also, it is very important at this point that we determine where is that implant position going to be relative to the adjacent teeth. And yes, it is at that point in time that we have to make that decision to determine whether we have achieved what we wanted or not. And as you can see throughout this, the buccal tissue and bone have not been touched. But yes, there is a gap there. And what does happen to it? And yes, we have seen also earlier, the literature, if the gap is 1.5 millimeter, it might fill with bone. It is possible. But that's not what I'm worried about. My concern is, can you maintain that ridge dimension if you did nothing? And therefore, if there is a void, you can expect collapse. In order for you to prevent collapse, that site must be filled completely. And not only just filled, it has to be very well condensed because, again, void equals collapse, and you want to prevent that collapse in that particular area. Then also you are dealing sometimes with anatomical limitation. You have maxillas and anterior maxillas that are very inclined, as you can see over here. And if you thought that a cementable restoration here will do the job, maybe you should think twice. Because if this implant is placed like this and the incisal edge or through the buccal, whatever abutment you and I can design, whether it is customized or personalized, it does not have enough retention, but also it is going to influence that complex over here, and therefore cause further resorption. So if you want to do something, then think maybe of a screw-retain approach for these particular cases. And maybe then the macro design of the implant should be very different to allow you to exit in the cingulum area without any influence in this particular part of the mouth. So let's share one particular case with you. This happened to be a ceramist that I do treat as a patient, and happens to be quite picky also. He had this particular tooth that was fractured, as you can see it over there. And honestly, initially, that was not going to be my direction going with him. But he insisted, and I thought maybe I do have an opportunity to help him. So of course, yes, we need to follow mesodistal position, buccal lingual. Here we are coming through the incisal edge, and you're saying to yourself, you just told us don't come through the incisal edge. And yes, you are right, we cannot come through the incisal edge. This is the direction that you are preparing the site with, but you are going to use an implant that is going to allow you to exit in the cingulum area. And this opportunity here is real, because once we do this, we are looking at this particular case, examining also that we have a mid-buccal bone in this particular area here. I had a fistula on this side, so I expected that not to have bone right here. We place our implant, and then I decided that we need to place a membrane, because this is no different than the socket classification that we had shown you before, or socket preservation. In a class 2 site that you are missing part of the buccal plate, you must use a membrane in order to repair it. And that's what we are trying to do here, combined with implant placement. Finally, we have the implant, we have the membrane, and this is the implant in position, and we have the graft material as you can see it over here. And we took this patient from here, we temporized him as such the same day, and he was good. But let's take a look at dynamically what happens with that site and what you need to do if your goal is successful result. So yes, we take the tooth out. You can select your technique of choice. The key here is that you do not approach the buccal plate in any way, and you do not negotiate it, because if you do that, you can expect resorption for sure. As we take this tooth out, we know right away that there is hard tissue missing right in this particular area here. And the protocol is the same. I like this particular type of probe because it is plastic, so it has some flexibility. It allows you to feel very well where that buccal bone is if you're not 100% sure where it is. And you need to understand that relationship between those two teeth as you start to prepare your site. So we start preparing our site. Again, we are completely away from the buccal aspect of the ridge. We try our membrane to see if it is going to do what we expect it to do in that particular position. You have to design it properly to somewhat overlap a little bit on the sides of the crest of bone. And as you can see, at the same time as I'm prepping my site, I'm probing the adjacent tooth to see where my depth is going to be, because that is the determining factor of success or failure over here. So whether you or your assistant, depending on how comfortable you are to do this, you need to keep that in mind, because of course it is a blind site and you're not watching everything that is there. You can see the depth of the pocket that I have here. This particular case, I decided that I did not want to immediately load it, just because of everything that was happening with it. So we place the membrane, but also in this particular case, the key here to success is that your space or the void that you are dealing with is grafted with bone, but not very little bone. You will be amazed that some of these sockets, actually, even with the implant in position, you have to place about 0.5 or more cc's of bone, which is a lot if you are condensing properly and placing your bone in the right areas where the gap is present. So we do this to achieve what we want. And I use always the analogy of amalgam. Amalgam used to fail because of poor condensation, and this will fail also for poor condensation. If you don't condense well enough, you can expect collapse. So you keep placing implants, bone till you no longer can fit anything in that space. And that's what we end up with. And you can see that even with all of this, we end up with some collapse. And this is very important for us to maybe take a few seconds and stop at this. Is this necessarily a failure? And it might be. It might be, because some of these cases, patients do come back and complain about food collection in that particular part. If I just wanted you that we were successful, let's take a look at this. Okay, that's fine. That's where he started. We brought him back to the same position. But that's not the goal. The goal is that ridge form will always continually be intact and without collapse. And maybe this is one of the cases that was an overkill. If that was an overkill, let's take a look at this one. Unfortunately, this case I end up treating, but I did not start the case. That's how I saw this patient. That's how she came to me, and the way she looked. And immediately in my mind, I said, okay, that's where you need to go. And of course, she went crazy. This is not what she expected, and that's not why she went with dental implants. But as I asked her, and I wanted to see, and I know the doctors that have treated her very well, I said, please let me see where you started. And if we look where this patient started and where she ended up, or where she's going to end up, clearly we have missed something. And that's my concern, that we are maybe swinging all the way or too far to one of the sides. So that's where she was. I said, let me see also some radiographs and some things. So yes, she has, maybe this tooth was definitely a hopeless tooth. Truthfully, I'm not sure about the other teeth at this point, because I never had an opportunity to look at them. And the thought was as following. Somebody extracted the two laterals. They used the centrals as temporization. They temporized her as such, with ovate pontics over here, and then they placed, with minimally invasive approach, the two laterals. But already we know that the two lateral sites collapsed, right? So maybe something was already missed there. So then I said, what else did you do? Well, they said, now we took, knowing that these collapsed, we want to do socket preservation on these. We took these two teeth out. They did a socket preservation. They used a membrane following the protocol that we have published on. And then they decided somehow maybe adding some connective tissue substitute could make it better. So they did. but they end up with this. So they realize that they have a problem, and that is not going to work very well. Well, if connective tissue substitute doesn't work, maybe connective tissue would work. So, and in particular, a pedicle graft. As you can see over here, the connective tissue is still connected here. And you can see clearly what is happening already in terms of sloughing in the palatal area. And that's what this patient ended up with. And that's what I'm talking about, is reducing treatment time and morbidity. This is the type of case that we need to avoid and prevent from happening. So, of course, knowing the work that David Garber and his team, Henry and Maurice Salama and Coachman, I said to myself, this is the best option to treat this patient. So I started to make some kind of provisional with chairside acrylic to see if that makes sense, and the patient would be very happy with this. And finally, exactly that's how we treated this patient. But also, keeping in mind that concept of going all the way with preservation and what we can do with it, let me share with you another case that was done by a very dear colleague of mine, and very talented also. As he showed me these slides, these are his slides, this is his work. And he said, Nick, you know, I did exactly what you said. I measured and checked for the mid-buccal bone on these teeth, and I placed these implants. And I also temporized immediately. And I said, you know, that's wonderful. Do you remember, this is the type of abutment that I'm telling you, that if your implant is coming too far buccally and you have nothing left on the buccal side, that it will influence what that hard and soft tissue will do. And they temporized the patient, and he was extremely happy. So he said, what do you think? I said, you know, I think it is great. But if the lateral failed, would you please let me know? I would like to treat this case with you. Unfortunately, he did actually call on me. And this particular lateral did fail. And you can see, I'm trying to show you some other examples. If people are trying to reflect the buccal soft tissue and to examine it, to see where it is in order to place their implant, this is what they could expect in some of the cases. And of course, cause recession and resorption for that site. So as this lateral failed, truthfully, I was going to attempt taking also the central out, but I wasn't really 100% sure that I'm going to deliver the results anymore the way this case was. So I tried to graft this site, and even with a graft that wasn't very successful, eventually we had to use an angled implant and use a screw-retained prosthesis, and we ended up treating this patient as such. But this is after the fact. This is after the fact. If you know that you are going to do this, you should decide for it before you go in. You decide for it before you go in because sometimes if your smile line right in this position here, maybe you have to reduce your bone and place your implants all the way up here in order to provide this patient with the most ideal pink ceramics that you could do. The reality is that this is here to stay. There are many of these cases that we are not capable to bring the hard and soft tissue to this level. And if we are not, let's be realistic. Pink porcelain can do it, but again, plan for it from the onset. Don't do it after the fact like I did with these two cases. And fortunately, I was lucky to finally get reasonably good results. I mean, if this patient had a slightly higher smile line, this case would have been an extreme failure and we would not have been able to resurrect it. But also what I want to share with you is that relationship between the lip pressure and the buccal bone resorption, with and without temporization. Yes, we all went to dental school and we all study anatomy, and somehow, you know, we know that it is there, but we kind of forget what it does and how it works. So if you look at the muscles of facial expression and the muscles of mastication, and you look at their origin and insertion, and of course the muscle action and what they do, you realize that they're doing a lot of things for us that we didn't expect or we didn't think that they do. The lip is supported itself by the anterior teeth. It is not supported by the bone. And therefore, if we place an implant and we place a provisional over it, we probably eliminated that pressure from this area here. as opposed to doing nothing and allowing the lip to come and invade that space. Invading that space is what is causing the resorption, and therefore end up with alteration of that alveolar ridge. So therefore, this is a protocol that we have been following and using for some time. This manuscript is in preparation. I'm working on it with David Kim and Brian Ehrlich that work with me in my practice, which they're amazing people. One is a periodontist and one is an endodontist, but they're both quite focused on implant dentistry and what takes place. Let me share with you that, of course, we know that pressure equals force per surface area, and how do we eliminate that? If we look at this patient and we look at her lip, how unsupported it is in this particular position, right? I go ahead and I place one abutment only. This is the same patient. I place one abutment only in here. Look what is happening to the lip over here. Is it creating pressure? Of course it is. Of course it is. It is us not being able to support it properly and keep the muscles where they belong that is coming in and invading that space and probably causing this resorption. It is no different than having an abutment or you have a natural tooth. This patient wears a partial over some implants over here. Look how well supported the lip is over here when you have a tooth. Why isn't it supported over here? And this is the one area that we need to put a lot of emphasis and focus on. Now look at this same patient when I placed another abutment. And look what happened to the lip over here compared to what I had over here. And furthermore, when you place your provisional, that you bring the muscles farther out. And therefore, possibly, we are eliminating that force that is coming into play and causing us that alteration of that extraction site, and we don't know how to overcome it in some situations. This work is not new. It has been published in the early 60s by plastic surgeons, how to avoid scars in the face following accidents or eliminating scar tissues. But I thought that's actually probably the oldest article that I could put my hands on. This has been published in the 1800s by a French anatomist examining the muscle actions of the face and the outcome that it has on plastic surgery. So this is really nothing new. It is not my thought. It is me looking carefully at what is happening in the mouth and the extraction socket that allowed me to think in that direction. And as we can see, as you exert, as we speak, as we smile, as we eat, and all of these muscles that come into play and exert their forces on the buccal bone. So what is the formula for predictable implant success? For regeneration, we need space, we need graft stability, we need barrier and containment, we need tension-free closure, and a graft material can play a major role in this. In my opinion, we need a graft material that is partially and solely resorbing, because over time, it can overcome some of the dimensional changes that can take long term. In regards to preservation, we need a buccal plate, we need a certain biotype, and that to me today maybe is a question mark because I've treated some patients with thin biotype and I'm waiting to see the outcome. We need implant stability. We must graft the gap, but also we need to think of the biomimetic of tooth form. The tooth must be duplicated in its entire form to prevent the muscles from coming into that space, and that's what will allow you success. The reality is, keep in mind that you follow all of these things: incisor edge position, interproximal soft tissue height, mid-buccal soft tissue, smile line, and all of this. There are some cases where you have to step back and say to yourself, you know what? I really want to use pink porcelain for this case because I know I can make it successful this way. How do we modify this hard and soft tissue response? There are a couple of studies that I would like to share with you regarding the inter-implant distance and crestal bone changes. So one of the studies, what we have tried to do, or what we looked at, is placing implants with different inter-implant distance of 3 and 4 millimeters, and then follow-up study with 2 to 3 millimeters. And that's based on that work that I told you, that anterior case, I was able to place implants that are 2 millimeters adjacent to each other, preserving the inter-implant bone. Know for sure that we can preserve that, but I will caution you again, do not expect that now that we can do this and that we can preserve the crestal bone, that your soft tissue volume is greater. It is not. It is the same volume that you had before, about 3.5 millimeters between 2 implants, which is different than the 5 millimeters between 2 teeth. This is the study that we have. We flatten the ridges. We place our implants using a guide to make sure that that inter-implant distance is always constant and stable. And also, this is the work of Emanuele Closa. What we are looking at now today, as opposed to only histology, we're looking at micro CT, and we're doing analysis to allow us to examine the implant surface in its entirety. Every thread, every 1 square millimeter of that implant we can examine and understand what is happening there. Is it for sure that we are preserving bone around the implant completely, circumferentially all around? What is happening on the surface of the implant itself? And what is that relationship between the connection? Clearly, histology can give you great opportunities to examine some of these things, but only in that cut that you have. This will allow you to examine the implant in all dimensions and in all areas. And of course, in the mini pig model, you can expect that there is some growth over here. But don't expect that to happen in human. It's whatever you have. We are very lucky if we can preserve it. Don't expect that there is going to be growth between two implants. So the conclusion is here that there was no differences between 2 and 3 millimeters. And this is great, especially for the aesthetic zone, if you absolutely need to place 2 adjacent implants. Another area that we need to look at, again, so that interaction between the connection and the implant and the response that is created. But how do we modify now goes a little bit further. Maybe enhance the implant body, whether physically or chemically, to enhance that response. So this is another study that I've worked on at NYU, and it is the mind behind the science is Jack Ritchie, a very good friend of mine and a great scientist, looking at the laser etching of implants and whether that can allow an opportunity for the bone and the soft tissue to respond differently. So it's a human clinical trial comparing the laser etching to 2 different implant systems. And we can see some of the results that we have, and it is unlike maybe some of the other implants. We can see that stability that we are seeing there, and also we can see the stability of the soft tissue. The goal here is, can we create an environment that mimics the natural tooth? Can we create an environment that will have supracrustal attachment and therefore maybe a greater soft tissue volume? It is possible. These, again, are some of the study. We can see clearly the stability of the hard and soft tissue over here. But now, thinking like somebody like Jack Ritchie, because he is the thinker that he is, he said, well, if this works now on the implant, why can I can't take it all the way to the abutment? And if we bring this higher up, maybe now our biological width is supracrustal, and therefore we will have maybe similar results as the natural tooth. In conclusions, preservation of existing hard and soft tissue is very important. Regenerate site prior to implant placement. And yes, I really do believe that we should think in the concept of 1 abutment, 1 time today. Mismatching between the implant and the abutment clearly has shown tremendous results, and many of the implants that we see today in the market are doing this. But again, do not expect a greater soft tissue volume because you have mismatching between the implants and you are preserving the crestal bone. The key here is to enhance the abutment design to allow epithelial attachment, and this is the macro design and chemical treatment of the implant. With this, I want to thank Dr. Picos and ICOI for this great opportunity to be here. Thank you.